view hasn't come.
No. That one, the nameplate on that is not real solid, and this one really kind of, where it's got marks on it. So, that may be the easiest, yeah, because they called me about, they asked me, what time do you need us? Look, it was supposed to have been done last week, but it's finished. So I need it by 11 o'clock. 11 o'clock,
Busy and
calls
sort of
and
busy,
says,
like busy
Kelly,
work. Pretty
you
good.
have if it's going to fall apart.
Yeah, you have.
I actually like
That's
it.
the first time I've ever. That's the
I
first
like
time
it
I've
very
ever.
well.
First time I've ever.
Suddenly got quiet, I feel like the pressure's on. We'll wait just another minute, make sure we don't have any other people strolling in, and I'll introduce our speaker.
I have a quick question. If some people ask me about the live stream, can they ask questions through the live stream or no? It's just projected?
Christopher's somewhere close by, and I think he's going to tell us, yes, they'll be able to ask questions.
Okay, good, because we have people in Central.
Yes, it will be at the end, Christopher. Okay, I think we'll go ahead and start. Welcome to our staff, faculty, and students gathered here today. It is my honor to introduce to you Dr. Scott Ebbinghaus. This medical school is 50 years old. Since 1988, we've recognized an alum who's excelled in their field, whether it be clinical education, research, or public service, as the outstanding alum. And this year, we're recognizing Dr. Ebbinghaus. He is a 1989 graduate of our school and a hematologist oncologist by training. And he's followed what I think is a path maybe less traveled by many of our graduates. Most of us graduate, find our way into clinical medicine, some in private practice, many in academic medicine. Some follow a path in academic education, research, or service roles. A few find our way to public health opportunities, but fewer to roles within the pharmaceutical industry, leading developments of new treatment that transform care. 15 years ago, after following a very traditional path, writing endless grants, staying up until the deadline, and I'm looking at Dr. Nichols, we just recently submitted an NIH grant, and I know she was writing until that very deadline had occurred. After writing many, many grants, being funded for many, many years, doing many clinical trials and finding his way, he suddenly found an opportunity to transition within pharma. And he made this leap over a period of time where he became the vice president for drug development for late-stage oncologic conditions. And at that point, I think this drug, Pembrolizumab, was known, but had not really found its place in medicine. And over a period of essentially 10 years, it has transformed the care of patients. And in fact, if you look at a list of within the last decade, the 10 most transformational changes that have occurred in the care of cancer patients, you will see this drug's development on that list. He's done this work while continuing to be a practicing oncologist, working every Friday at the Fox Chase Cancer Center in Philadelphia. And I'd just like to say that as we looked at the letters nominating him for this award, they all praised his vision, his passion, and his commitment to improving the outcomes for patients with cancer. And that's truly exemplified not only by what they saw in him, but his own spoken words, where as he's engaged in care of patients, he wants to maintain their optimism and ensure that they are getting the cutting edge care. We're truly honored to have what I consider a healthcare pioneer in our midst today and a graduate of our school. Dr. Ebbinghaus, welcome back to UMKC.
Thank you. Thank you very much. Well, thank you. I'm truly honored by the opportunity to get this award, but also to address you today. I'd like to recognize my good friend and also an oncologist, Robert Ellis, who nominated me for this, and appreciate that, Robert. Thank you very much. And I'd like to talk to you today about the development of immunotherapy that brought us into, I think, the 21st century for cancer care. So I'm going to talk briefly about the development of the history of the development of Keytruda and two of its first indications in melanoma and lung cancer, talk a little bit about what we're doing right now, and then what's next for Merck Oncology. And I'm going to try to, address a question which is, is pharma the dark side, and I hope I convince you that it's not, and that the impact of drug development on the course of human health is quite profound. So just this month, Keytruda passed an amazing milestone, which is 1 million cancer patients have received Keytruda. And so I'm very proud to be on the team of people that helped to make this happen. Keytruda, or Pembrolizumab, is an anti-PD-1 antibody. So PD-1 basically is a protein on the surface of the T cell, and that's what Pembrolizumab binds to. It's a monoclonal antibody, and what that does is that prevents the PD-1 protein from binding to a protein that's commonly expressed on the surface of cancer cells called PD-L1. So our body has a way of sort of fine-tuning the immune system. This helps us prevent autoimmune disease and that sort of thing, but cancer cells have sort of evolved the expression of this protein to tamp down the anti-cancer immune reaction, and so by preventing PD-1 from binding to PD-L1, you can actually allow a T cell to now work and find the cancer cell and affect its and cause cytotoxic effects. So just a little bit of audience engagement. So this work, the discovery of the checkpoint inhibitors led to the Nobel Prize in 2018. So anybody have any guesses as to which of these famous scientific pairs or triplets were the ones to discover how to, quote unquote, block the brakes of the immune system that underpins the science behind Keytruda? Hanjo and Allison. So that's correct. So Jim Allison and Tasuko Hanjo. And a little bit of further trivia, Dr. Allison actually plays the harmonica for a blues band called the Checkpoints. So the history of Pembrolizumab dates back, at least for me, to about 2011. There's a backstory behind that I would be amused, people would be amused to hear about, but I won't tell that in this audience. But we started with a simple, as we often do, dose escalation trial to identify a dose of Pembrolizumab. The Keynote 1 study, which somebody who works for me now named Peter Kang was the original clinical director of at Merck, wrote that trial, was supposed to have 32 patients. And what happened is we observed, the royal we, because I wasn't involved at this point, some really striking evidence of activity in patients with metastatic melanoma who'd failed multiple prior therapies. And so we expanded to 60, and that's kind of where I started to get involved. And then we just sort of took this phase 1 study, which was intended to be the first in human trial, and kept making it bigger and bigger and bigger, and the FDA has sort of said ixnay on that kind of trial design in the future, but this was a way that we basically were able to develop pembrolizumab and get it from first in human to approval for the treatment of advanced melanoma in just over 3 years. So these were the data that we had in hand in sort of around the end of 2012 when I joined the program. So we had in patients with melanoma about a 40% response rate. We saw responses in patients who were naive to a drug, another checkpoint inhibitor drug called Ipi, which was sort of the first generation of immunotherapies, and we saw a pretty decent response rate in patients who had previously received this treatment. And so this is an example of the type of response that we saw. This is a CT scan from a patient at UCLA of an investigator who's become a good friend of mine named Tony Rebus, and you can see this huge mass in the chest, this liver completely occupied by tumor, and from 1 year to the next, this has almost completely disappeared. And moreover, this is what the patient looked like at the time when the first CT scan was taken. You can see for yourself that he looks quite sick, and this is what he looks like a year later after improvement of his cancer through this treatment, and this patient actually is alive today. So through Keynote 1 and a number of these milestones, we had the first ever breakthrough therapy designation from the FDA in 2013. We went from, as I said, from first in human to approval in about 3.5 years. And then since then, we've carefully evaluated this drug in melanoma and many other diseases to confirm that it has benefits. I'm going to show a fair number of these of the graphical on the right, which are called Kaplan-Meier curves, and this is a way that in oncology we compare treatment arms, and in this case we're looking at overall survival, which is the ultimate arbiter of success in oncology. So this is Keynote 6. This was a trial where we were looking at the time when we developed Keytruda, it was a little bit like building the plane while it's in flight, and we had 2 wings, but we didn't maybe have the tail fin, so we didn't actually know what dose of Keytruda we wanted to use at the time when we had to make decisions about pivotal clinical trials. And so we actually did randomized comparison of 2 doses of pembrolizumab compared to the standard of care. And as you can see, the dose doesn't really matter much. Both arms are significantly improve overall survival compared to ipilimumab. We showed also that even in patients who were refractory to everything under the sun for their cancer, you could have a trend towards improvement in overall survival and a profound improvement in progression-free survival. And so Keytruda became a standard of care for the treatment of advanced melanoma, sort of regardless of whether it has received prior therapy or not. And I'm happy to say that we've now been following these trials for a long time. And these are curves that you just can't imagine, having seen. If you look at the control arm of the curves here, where when we used to treat melanoma in the 2000s and earlier, it was mostly with chemotherapy like dacarbazine. Most patients progress within a year. And so having these nice flat tails on the curve like this are pretty profound, and it's just fascinating and gratifying to see that even at 7 years, almost 40% of melanoma patients with metastatic melanoma are alive and well. And my son, who overslept and is maybe on his way in the taxi or not, is pictured here. This is Nicholas Ebbinghaus in 2015 and what he looks like now, just to show what a difference 7 years makes and what a difference 7 years can make in the life of a cancer patient. Maybe you see your son, your son, your daughter, your nephew, your niece graduate from medical school, for example. So what we've been doing now is moving pembrolizumab earlier and earlier into the treatment paradigm for cancer. Immunotherapy may be ideally suited for sort of the earliest stages of disease, where if you can sort of activate your immune system to fight the cancer, you can maybe prevent patients from ever developing metastatic disease. And so we have a very active adjuvant therapy program, the first of which is in melanoma. So the idea of giving adjuvant therapy is that at the time of surgical intervention, you may have micrometastatic disease, and you want to try to sort of clean that up with the systemic therapy and have the potential to maybe cure more patients. And so Keynote 54 is a trial in melanoma where we showed just that. This is, again, a Kaplan-Meier curve showing pembrolizumab versus the available standard of care. In this case, no therapy at all was standard for melanoma, so it was a placebo-controlled trial. And you can see that there's a big difference in the outcome of patients who got this treatment after surgery for melanoma, which was completely resected. And then to bring us right up to 2022, we'll be presenting data at ASCO showing that this observation extends to patients who have stage 2 melanoma, which is melanoma confined to the skin, although maybe deep and at high risk of recurrence, that you can improve recurrence-free survival and a surrogate endpoint called distant metastasis-free survival. So I'd like to turn now to lung cancer. So similar story in lung cancer. Again, starting with observations from Keynote 1, striking responses in lung cancer. And at the time when we saw this, I mean, this was pretty amazing because no immunotherapy had really ever shown any activity in non-small cell lung cancer. And so on the basis of the Keynote 1 study that got Keytruda approved for melanoma, we also had a second approval for patients with non-small cell lung cancer who had high expression of the PD-L1 protein that I told you about, and had received prior therapy on the basis of the overall response rate here and a remarkable duration of response. And I'm again proud to say that this is another truly amazing curve where we followed patients who were on this initial Keynote 1 study now out to 5 years and beyond. This was presented at ASCO in 2019, showing a 5-year survival rate in metastatic lung cancer of almost 1 out of 4 patients. I think that tells us two things. One, this is tremendous progress. This curve would essentially sort of, go down to 0 over 2 or 3 years in the era before the anti-PD-1s, but it does show that 75% of patients are still dying of lung cancer, even in spite of the progress that we've made so far. So we have a lot of work still left to do. So we've now completed a series of randomized controlled trials, again, to carefully evaluate pembrolizumab's role in the treatment of lung cancer, looking at it in the second-line setting, looking at it as monotherapy in the first-line setting, and then looking at it as combination therapy for with chemotherapy in the first and second-line setting, and then lastly, in a sort of new approach in the adjuvant setting. So Robert Ellis and other oncologists in the room will know that the treatment for lung cancer for decades was platinum doublet chemotherapy. This is a very famous curve that was published by Joan Schiller in the New England Journal in 2002, which pretty much, the conclusion was that pretty much all platinum doublets were sort of equal. And it was felt for many years that we'd reached a therapeutic efficacy plateau because every attempt to sort of make this better just failed, and every attempt to sort of add a third drug on, there are just, literally hundreds of studies in the medical literature of platinum plus paclitaxel plus drug X, which basically failed. And so platinum doublet chemotherapy for two plus decades was sort of the 800-pound gorilla. So we had the audacity to think we could beat that 800-pound gorilla. And pembrolizumab, in a study called Keynote 24, actually was able to displace platinum doublet chemotherapy as a standard of care in patients that had high PD-L1 expression. And these data show the improvement in overall survival and the improvement in objective response rate that you get in patients with metastatic non-small cell lung cancer with high PD-L1 expression. So the next trick or the next question was, if you combine with platinum doublet chemotherapy, is that even better? And it appears that that is actually even better. So patients with advanced lung cancer have two options. If they have high PD-L1 expression, they can get treated with monotherapy. If they have lower levels of expression, they generally would be treated with a combination of chemotherapy and immunotherapy. And then again, to bring us right up into the 2020s, a couple of weeks ago, we shared these results at a virtual plenary of ESMO, and this is the outcome of adding pembrolizumab on in the adjuvant setting for non-small cell lung cancer, where we've shown an improvement in in disease-free survival when pembrolizumab is added to standard therapy postoperatively for lung cancer. So that's a history of the first two indications from roughly 2011 through present on for Keytruda. Keytruda has now been approved in at least 16 different tumor types. It's approved in 90 countries around the world. We have two very unique tumor agnostic approvals where pembrolizumab is indicated for the treatment of cancer regardless of histologic type, if that cancer has either high tumor molecular burden or microsatellite instability, high tumor characteristics. Oops. This is a series of plots which are called waterfall plots, and I won't go into what they mean, but they're a means of evaluating anti-tumor activity, usually in phase 1 or phase 2 studies. And this shows that Keytruda has activity in a wide variety of tumor types. What I'm particularly proud of is that in randomized controlled studies, we've demonstrated that this anti-tumor activity over and over again translates into what really is very meaningful for patients, which is an improvement in overall survival. Any one of these curves would honestly be the culmination of a lifetime a lifetime career. And it's just humbling to think about having been able to do this in melanoma, lung cancer, bladder cancer, liver cancer, head and neck cancer, again and again. And that's with Keytruda on its own. We've shown that Keytruda can integrate very nicely with standard of care treatments, many of which are shown here, and again, further improve on the treatment of cancer. And then in the adjuvant setting, where I think Keytruda will and other anti-PD-1 drugs will really make a huge impact on the overall burden of cancer in the world, we've been able to again repeatedly show that this is a major impact. So we've now treated about 1 million patients around the world. We have 1,750 clinical trials in at least 31 tumor types with Keytruda, and we're still actively evaluating it. Our strategy is shown here, and I won't belabor it, but it basically builds on a foundation of treatment with Keytruda to combine and improve upon that, and then, of course, to identify the patients that are most likely to benefit. We're quite committed to this early disease state, and I'm proud of the fact that we've had some early success, but look forward to seeing hopefully many more. We have about 20,000 patients in 25 pivotal studies in 11 tumor types, looking at pembrolizumab in early disease states. And we have a lot of activity going on in combinations. Sort of based on the early success that we saw with non-small cell lung cancer, we've we're evaluating or have evaluated chemotherapy combinations across all these tumor types. And we've had some really interesting results when combining pembrolizumab with anti-VEGF therapy. These are two studies where we've demonstrated overall survival benefits when pembrolizumab is combined with an anti-VEGF therapy called lenvatinib in either endometrial cancer or renal cell cancer. And we have a program that we call our LEAP program where we're evaluating this combination quite thoroughly. And lastly, we spent a fair bit of time and energy to try to identify those patients that are going to benefit the most. So we've developed several diagnostic studies that are available as clinical tests that you can get for your patient's cancer. One evaluates the expression of PD-L1 on tumor cells and was the first companion diagnostic, and it's useful in a number of different cancer types. And the second are genetic tests looking at whether tumors have high rates of mutational burden and high rates of microsatellite instability. And those likely create a situation where tumors express what are called neoantigens, and that likely renders them more sensitive to immunotherapy drugs like pembrolizumab. And so these are tests that you can do to identify patients who are more likely to benefit from immunotherapies like pembrolizumab. And a couple of examples here of data showing that. So in MSI-high colorectal cancer, pembrolizumab was compared to chemotherapy in Keynote 177 and showed just a really profound benefit in comparison to chemotherapy. And then we have on the left side a study called Keynote 158, which was the pivotal sort of phase 2 study where we have approval for pembrolizumab in what's called tumor mutational burden high cancers. So I'm proud to work at Merck. I'm proud to say that we have a pipeline that lets us really think about continuing to transform the way we treat cancer into the 2020s and beyond. And I've spoken a few times that I work at Merck. We are a company. I'm happy to say that we reinvest a lot of the money that Merck makes into research. We probably have one of the biggest research budgets in the industry at about $14 billion per year. We have about 68,000 employees. And for the people that are early in their career, I guess I'd like to ask the question, is this the dark side? One answer to that is just to look at along the timeline of developments that made a big impact on human health. So Merck was one of the very first companies to be able to mass produce penicillin, for example, in World War II in 1942. Nobel Prize winning work done at Merck developed a cure for river blindness with an anti-filarial medicine, and then recently developed the first vaccine for Ebola virus. And you may have your own feelings about the value of molnupiravir, but we've done our best to try to contribute to controlling the current pandemic for COVID. This is my current boss. He normally looks a little like this, but he's the chief medical officer at Merck, and the current chief medical officer at Merck. And he's on vacation, and one of his major contributions was the development of Gardasil, which was the first vaccine for HPV. And if you look at the figure on the left, what you see is that if you, in a Swedish registry, if you vaccinate children before the age of first sexual contact, you can reduce the rate of cervical cancer down to virtually zero. And so Eliav is on vacation in Laos in Southeast Asia, and he's pointing to a tapestry type of thing where they're showing all the vaccines that people need to get, and he's pointing to the one where it says that you need to get Gardasil. And the picture here is of a little girl waving the Laotian flag, riding an elephant, which is the national symbol of Laos, and carrying a vaccine. So here's to Ilya for his contributions to that in drug development. And we do have a North Star, which is this great statement by George Merck that medicine is for people, not for profits. So I'd like to pay homage to the many mentors that I've had along the way. They're pictured here, and it was actually quite a bit of fun to put this slide together. I'll point out, too, that we're here at the UMKC School of Medicine. Dr. Ellen Lichten, who's still active at Cleveland Clinic, was a mentor of mine who introduced me to clinical research, and I did a clinical research project, a translational clinical research project with Dr. Lichten in around 1987 through 89, and then my docent, Dr. Bill Isley, who unfortunately passed away at an early age in about a little more than a decade and a half ago. All good things that I've done can be directly traced back to the people you see pictured here. Any mistakes I've made, I own. So, anybody know what this is? So this is the end of my talk, so that's good. But this is a ceremonial bowl, which is called a silver sakazuki. And the significance of this is that in Japan, they would give this ceremonial bowl out to citizens of Japan who turned 100 years old as a gift from the Japanese government. And so, in 1983, they gave 153 silver sakazukis. By 2015, they gave 58,000. And if that isn't a testament to the impact that we have on human health, I don't know what is. And the punchline here is that Japan has given so many of these gifts away that they actually discontinued the program because it got too expensive in 2015. So with that, I'll stop and happy to answer any questions. Yes.
So you mentioned earlier that you use a combined therapy for patients that have low PD-L1 expression. Are there thoughts to engineer tumor cells so that they can increase the PD-L1 expression so that Keytruda will be more effective in the tumor cells?
Yeah, we've spent a ton of time thinking about that, and much of the combination therapy that we've done is sort of with the intent of altering the tumor microenvironment so that you can sort of make what they call a cold tumor into a hot tumor. The proof of the pudding is always sort of in the eating, as they say. So far, combination IO strategies have been less exciting than we hoped. We've done exactly that. You can show that you can increase PD-L1 expression, but it hasn't been as sort of profoundly beneficial as we've hoped. What we're seeing with combination immunotherapies is they work in some tumors. They probably add incrementally, but they haven't been sort of the next revolution that we'd hoped for. Yeah.
I remember in the melanoma data you showed basically if they made it past the first 12 months or so, then they're on the flat part that more or less went on 7 to 8 years, and longer probably. Are there characteristics of that group that falls away in that first year? Is it just PD-1 titer, or is it other things, or they're very late stage and not healthy anymore?
Yeah, we've dissected that a bit. So the factors that are the most important in predicting who's going to get the complete responses or the durable, long-lasting responses. We've published with Dr. Caroline Robert from Institut Gustave Roussy, and there are sort of four main factors. It's and they're not particularly profound, unfortunately. One of them is PD-L1 expression. That plays an important role. And then the other three are sort of patient factors. So it has to do with LDH, which is a measure of tumor burden, the median tumor volume at baseline, and then sort of combinations of those factors, basically, at least from what we've been able to measure based on sort of retrospectively mining our clinical data. Back there.
One of the things that really strikes me about the action of this drug is that it's so specific in terms of, I mean, if you look at these patients before and after treatment, you don't see the deterioration or the attack of other tissues.
I'm sorry,
Other tissues, any other, just, it's really specific. So really, I guess what I'm getting at is, can you comment on the other mechanisms that are involved in preventing autoimmune that are somehow not activated by this?
So first, I didn't unfortunately or fortunately spend any time at all on adverse events, and that's probably that you should always have balance when you talk about these things. Most people want to hear about how good it is, not necessarily about what the bad things are that it can do to you. But these drugs do have side effects. There's no question about it. And the side effects are interesting because they're absolutely nothing like what you would expect with chemotherapy. So you don't get nausea, vomiting, hair loss, any of those sort of standard things. But what we have is a whole gamut of immune-related adverse events. The most common is thyroid, actually. So you get thyroiditis, hyper and hypothyroidism. So that tissue is the one that sort of is the most susceptible to inhibiting this axis in normal tissues. And about 1 out of every 10 patients that takes Keytruda will end up having to go on to thyroid replacement hormone probably for the rest of their lives. But you can see an immune-related reaction in virtually any tissue, and about every 6 months or so, we update our label to say, okay, we found another one. I think the most recent one that we just discovered was sclerosing cholangitis. It's very rare, but it happens, and so we are constantly monitoring for these things to make sure that we can inform people of what to sort of look out for. So so these things do actually work on sometimes have adverse effects on normal tissues.
Hi, Scott. It's a great work. So I'm a basic scientist. Always my dream to find something really for the clinical settings. For your study, did you test anything for this drug for the brain tumors? Because now we have no effective treatment for the tumors. Did this drug have some kind of effect?
Yeah,
for the brain?
That's a great question. Boy, we would love it if we could make this drug work in brain tumors. So far, attempts to so there's a few places where anti-PD-1 therapies haven't worked, and we're still struggling to one understand why, and two to try various maneuvers to see if we can sort of again make these drugs work if we put them in combination, so that those tumors can kind of reap the benefits that other tumors can. Brain tumors, pancreatic tumors, and a lot of the sort of hematologic malignancies, except for Hodgkin's disease, have not been sensitive. I don't have good insight into why that is. I doubt it has to do with the blood-brain barrier, because the effector is actually not the antibody. So whether the antibody penetrates into the brain or not is probably not relevant, because the T cell is actually what's doing all the work, and you can activate the T cell in the periphery; it'll get into the brain just fine. But we have studied that quite extensively. And both us and the BMS who makes the drug nivolumab, which is a close cousin to pembrolizumab, have studied it in brain tumors without activity. Now, we haven't given up. We actually have we're actually initiating a trial with a combination with Keytruda and this sort of new device for brain tumors, which is called Optune. I don't know if you know about Optune. Sort of put this thing on your head, and it has tumor treating fields of electricity. I have no idea how that device works, but it does apparently, and it's approved in the U.S. It's been scrutinized heavily, and it actually does work. And they've got some exciting preliminary data putting Keytruda together with this sort of tumor treating field. So maybe that's the secret sauce. But we're moving forward with a trial to formally evaluate whether that, sort of combination is going to work in brain tumors.
Have you studied any other immunotherapies, and have you tried any combinations with Keytruda?
Yeah, we've got a fairly extensive program, looking at that actually. So there are a number of other checkpoint inhibitors. Again, if you look at sort of, you can make a figure of a map of these, and there are agonists and there are antagonists. And the two front runners right now, and these are not only studied at Merck, but studied sort of across the industry, is one called TIGIT and another one called LAG-3. Those are probably the two that are most studied. There was a clinical trial of a combination of an anti-LAG-3 antibody and Opdivo or nivolumab in melanoma. And what they showed was that you could sort of improve progression-free survival modestly by around 20% with that combination. But the nice thing about that is that the two drugs really don't appear to have a heck of a lot of added toxicity over giving just one. So it's a pretty easy combination to take. But that's an area that's being intensely studied, in drug development right now.
We're seeing more direct-to-consumer advertising for oncology. I want to get your take on that.
Yeah, boy, I tell you what, I took a couple days off and went skiing with the family, and so I watched, and there was no cable TV, so I watched like network TV in the morning, and I was just like floored by the DTC advertising, how voluminous it was, and you definitely can't watch a football game without seeing advertisements for Keytruda and Opdivo. Physicians hate it. I mean, there's nobody at Merck in the Merck MRL side of oncology that likes it. I mean, on the one hand, okay, probably raises awareness. Consumers need to be part of the process, but I don't like it. So, yeah.
There's some data that suggests that different cancers are expressed differently in different populations. Like the colorectal cancer in the Chinese population looks a little bit different than it does in the U.S. So, as you studied this from around the world, are there any differences population-based?
Yeah, I think that's a great question, and one that we get asked by regulatory authorities, commonly. Broadly speaking, there's no differences in pharmacology. So, looking at Dr. Cuddy back there, so the important thing is that the drug itself is sort of all the pharmacologic characteristics are pretty much the same, whether you're by race, by ethnicity, by country, whatever you want to study it. And we've done an extensive population PK program to evaluate that. In clinical trials, of course, you do 1,700 trials, you see differences, and it's sometimes hard to know whether those differences are biologically based or due to chance. There may be some differences in Asian patients with certain upper GI tumors. That's the one place where we've sort of consistently seen that squamous cell cancer of the esophagus, where pembrolizumab works pretty well. Looks like it looks better in Japan than anywhere else in the world. Maybe it's the Japanese are just better at taking care of esophageal cancer patients. I'm not sure, but they do very well in Keytruda trials. But we keep an eye. We look at that very closely.
I just want to follow up on that. In terms of clinical trials, one of the things when we were developing COVID vaccines was to ensure that we had adequate representations of different races and ethnicity. It was a very intentional move because we know that clinical trials have often left out certain patient populations.
Yeah.
What was the strategy here?
Yeah, I mean it's an area that it's an area that really right now requires intense efforts on the part of all stakeholders. I think it needs efforts on the part of pharma, and where we pick sites, it requires efforts on the part of, the academic community that, usually is doing these trials to ensure that we get a population of patients that, is representative of the population at large. Over the large trial program that we have, I think we have had adequate coverage of underrepresented minorities, but I would give us a C on how well any individual trial does at recruiting minorities. I would say our biggest success story is a recent trial that we did in prostate cancer where we were able to get about 10% African American men. It's still not close to what it needs to be, but that's beating most every other trial that's ever been done in prostate cancer. Others we've struggled to get, to get those. One comment I would make is that in most of what we do what are called multi-regional clinical trials. So our trials are done globally. We get about 80% of our patients outside the U.S., about 20% in the U.S., and that's pretty typical.
Have you looked at whether binding of Keytruda to the receptor induces any intracellular changes in genes downstream of the receptor? Because I noticed in one of your slides you had that it was effective in patients that are BRAF1 positive. There's a lot of gene changes that happen in sort of the gamma interferon pathway. And we actually have developed an 18 gene signature, which we call the T cell inflamed gene signature, that sort of can help to evaluate tumors that may have sort of a microenvironment that's amenable to PD-L1 to sort of PD-L1 inhibition. So there are a number of changes that happen in that pathway. The BRAF story is interesting, and that's really kind of a specific one to malignant melanoma. So the two big advances in the therapy of melanoma have been, one, on the immunotherapy side, but also on the targeted therapy side. We have treatment. About 50% of patients with melanoma have a mutation in their BRAF gene that activates that pathway. And so one strategy for treating melanoma is to sort of use drugs that inhibit the expression of that pathway, either BRAF itself or downstream of BRAF in a gene called MEK. And if you hit both of those, it actually works the best. The problem with the targeted therapies are that eventually everybody develops resistance to them. If you in the old days when we used to use monotherapy against BRAF, you could almost set your calendar by the resistance, which would develop sort of like clockwork after about 6 to 8 months. And then the cancer would sort of come roaring right back. It's better now with combinations, but there are actually ways that you can combine combine those two strategies, and that's been and is being done.
Is there any role for Keytruda in combination with CAR T cell therapies?
Yeah, so the answer is not today. But it's a great question. One of the things that I've really admired about working at Merck is that we've been extraordinarily collaborative. I think we've been ahead of the curve. Back in 2007 when I started working at Merck, it was unusual for two drug companies to sort of work together. And we went. GSK is actually 25 miles away from the headquarters of Merck, and we know all those guys, and we're like, hey, you guys got this, we got this, let's put them together. I mean, it's only going to benefit cancer patients. And the lawyers got together and said, yeah, you could probably do that. What's yours is yours, what's ours is ours, and we won't try to claim intellectual property on any joint discoveries. And that set off in motion this ability to collaborate. So right now we collaborate with 165 companies
when we give Keytruda to those companies who want to test it, and we have a number of efforts looking at Keytruda with cellular therapy. I haven't seen anything yet that shows me that whether or not that's going to work, but we're actively investigating it. So it's an interesting idea and an interesting strategy.
Are there any advances coming with the small cell lung carcinoma? I mean, the small cell is always the one that everybody says we can't deal with.
Yeah, small cell's been a tough one. It's there are chemotherapy combinations with anti-PD-1s which are approved and used in the clinic. Pembro isn't actually one of them, but and that's interesting. So in my clinic, there are right now 5 approved anti-PD-1 or anti-PD-L1 therapies, and in my clinic I use all 5 of them depending on what the circumstance is. I would say that the benefits of anti-PD-1 therapy are pretty modest in small cell, and it's an area that we may need a different strategy entirely. Dr. Ellis.
Yeah, Scott, my introduction to this area was trying to give IPI at 10 milligrams per kilo,
Yeah.
which never really went very well. And so my question is going to be about managing the side effects. And oftentimes we'll do kind of steroids and Rimicade, Humira. I mean, there's a number of immunosuppressive drugs we can use. Have you found that one or the other of them is where when you use that drug, you can't get the drug to respond anymore? Is there one that just cancels out? Where is there any one drug more than the other that's like that?
Yeah. So thanks for the question, Robert. We've looked obviously most extensively at corticosteroids, and the question was, if you give corticosteroids, will it sort of, that's sort of the whole strategy for giving corticosteroids is you want to sort of, inhibit the function of the T cell, and the whole purpose of giving Keytruda is to, sort of make the T cell work better, right, against cancer. So, the question is, would, if you give those together, do they sort of, cancel each other out? So what we know is that in immunocompetent mouse models, there's no inhibition of PD-1 with high-dose corticosteroids. In human clinical trials where we sort of retrospectively looked at that, once you have a response, there doesn't appear to be any sort of danger to giving corticosteroids. Like, in other words, you don't lose your response. The durability of responses seem the same. Now, if you haven't yet had a response and you give a corticosteroid, the response rate is lower than in those patients who haven't had a corticosteroid, but with the caveat that, that's a very, the trials weren't designed to answer that question, and it's awfully confounded, right? Because when you're giving a corticosteroid, somebody's sick, they have SAEs, all that sort of stuff, and it's confounded. But that's what we found so far in trying to answer that question.
I'm going to sneak back up to the microphone. First, to say thank you to Dr. Ellis for bringing Dr. Ebbinghaus to us. This was a fascinating discussion, obviously a high level of interest, and we're very proud of the work that you're doing and will continue to do. I want to have Dr. David John come to the microphone now. He's our Associate Dean for Alumni and Community Engagement to officially present the Take Wing Award to you.
Thank you.
The UMKC School of Medicine, now ending its 50th year, has graduated over 4,000 physicians who serve health institutions and academic centers across this nation as clinicians, educators, and researchers. Since 1988, on an annual basis, we have recognized an exemplary graduate with the E. Gray Diamond Take Wing Award. This award honors physicians who demonstrate excellence in the practice of medicine, academic medicine, or research, and who demonstrate the highest level of professionalism. Past recipients have been department chairs and section chiefs in medical schools, national leaders in research. They've developed local and international service missions, or have innovated and led in clinical care. On behalf of the UMKC School of Medicine, I am honored to present to you Dr. Scott Ebbinghaus with the 2022 Take-Wing Award. Thank you.
Thank you very much. I appreciate that. This is.
For others who have questions, if you'd like to stay, I know Dr. Ebbinghaus would be here to answer for you. Hey, Dr. Gardner. Good to see you. Where do you guys
I got lost. Went to the wrong school. I came all the way down here and got lost. Yeah, the other.
Oh, that happened. Oh, my gosh.
How you doing? Yeah, we better over today. How much of it did you see? Last 2 minutes. Not last 2 minutes, but last like.